Okay.
Yeah, I think so.
Is this recording?
If it's on. Yeah, go for
Okay,
it.
great. Okay, so thank you so much, Devorah, for inviting me to speak. And thank you, Ariella, for opening your home. And thanks all of you. I think it's really amazing that you're giving your 7 to 8 p.m. at night for so many weeks in a row to learn and to be able to be useful to people in the community. So I think it's really amazing. So I think that one of the most interesting things to me was when I was training to be Watzat Halacha, they told us that most of the questions that are received on the hotline and the website are about postpartum issues. And I was like, really? Now the truth is, and I was thinking about it, I think probably like 60% of my questions are also postpartum questions. And I think that speaks to the fact that there are so many issues that can come up and there's so little preparation. Like nobody really knows what to expect when they're expecting or after they're expecting, right, in the 4th trimester. So I think it's really great that you're being educated about this, like, sort of part of the process. And what I want to do tonight is I want to go over, like, the top 10 challenges that I think women face so that hopefully you'll have a better sense of things that can come up and possible solutions and possible directions. So definitely feel free to interrupt me if you have any questions. If you ever want to reach out to me, my contact info is here, and you can feel free to send it to whichever woman you may encounter. Okay, so challenge number 1 is bleeding. Okay, with most questions that we deal with here. So the normal amount of time that a woman bleeds for is 6 to 12 weeks. Now, I don't usually like to tell a woman, like, you might bleed for 12 weeks because that's a little bit scary. But if someone calls and they're like, okay, it's 6 weeks, why am I not bleeding? Then I would tell them, like, you could bleed for longer. I wouldn't say 12 weeks because that sounds scary. So one thing that I think women don't know is that it stops and then it starts again. So a lot of times women will call and say, okay, I had a baby 2 weeks ago and whatever, I stopped bleeding. So can I go to the mikvah? And I'm like, well, first of all, there are some medical issues with that. And second of all, you might start bleeding again. So I would just recommend that you wait a little bit longer until you're sure the bleeding has stopped. Because otherwise it becomes extremely frustrating to try to get through the 7 clean days and then try again and try again. So if a woman is bleeding, I think for 8 weeks or longer, I would direct her to her doctor just because it's probably normal. But I think that, since most women are able to get to the mikvah around 6-7 weeks, if someone is still, seeing a lot of blood at 8 weeks, I think it's a good idea to just say, probably everything's fine, but maybe you want to go to your doctor and just check in about that. Okay, so the bleeding period is so hard. First of all, because it's just annoying to bleed for so long because of the physical reasons. And also it's obviously a very emotional time, and I think one of the things that couples struggle with the most is that there's no touching. You're allowed to pass a baby. There's a debate about it, but that's the psak that I follow. But it's a time when you would want to touch your spouse, and that is not allowed. So that's something that I think a lot of people really struggle with, and I've definitely spoken to a lot of hysterical women about this and tried to help coach them through it, and it is just a hard time. So it's also challenging, right? Because intercourse is not allowed. I think that there is often a gap between the males and the females. The females are whatever, I don't want to, that's scary to me, everything is so sensitive, I was just bleeding, I just had a baby, and the men are let's go, I really want to have intercourse. I think there is a gap. Okay, so the next challenge that comes up is starting b'dikot. So how do you get through the 7 clean days? So there are 3 different factors that I think we need to consider when we think about when a good time to start b'dikot is. So the first one is medical factors. The second is the halachic requirements. And the third are psychological factors. So we're going to go into each of those. Okay, so medical factors, okay? So doctors will tell you that you should not be inserting anything vaginally for 4 weeks postpartum. So even if someone would want to start before then, I think that medical advice needs to be trump everything, meaning whether or not halacha has anything to say about it. Medically, doctors do not want anything inserted at 4 weeks minimum, and they'd probably prefer 6 weeks. Intercourse is not allowed, even if a person can get to the mikvah, by most doctors before 6 weeks postpartum checkup. More handouts, yes. And the other complicated factors are that often women have stitches, or they have tears, or they have vaginal dryness due to low estrogen levels, and we don't want them to start at a point where they're going to end up cutting themselves and cause more bleeding. So I think that, like, when women call me like at 3 weeks and are like, hey, like I want to start going through my 7 clean days, I think to coach them to think long term as opposed to short term. Like short term, like yes, right now you wanted to go to the mikvah next week, but long term, right? Like if you cut yourself because you're doing a bedika, like you're gonna set this whole process like back by a few weeks, and it's not going to be worthwhile. So I think that the risk kind of outweighs the benefits often. Okay, so in terms of halachic requirements, so I think a lot of people learn the psukim in the Torah about if you have a boy and you have a girl and how long you have to wait. So halachically, minimally for a C-section, you need to wait just 7 days to start getting through your 7 clean days. And oftentimes women who have C-sections are able to get to the mikvah earlier, even though they also do have some vaginal bleeding. For a vaginal delivery, the minimum for a girl is 14 days plus 7 clean days. Practically in real life, like this doesn't happen. No one's going to the mikvah at 3 weeks, but like in theory, right, that could happen. And for a boy, it's 7 days of bleeding and 7 clean days. Okay, but that ends up really being irrelevant. So one can start the 7 clean days even if they're still staining. A lot of people feel like they have to be seeing nothing in order to start. As long as a person can get through the 7 clean days, can insert the bedika cloth, and it will come out with a appropriate color, which is not red, pink, or black, and they don't have any stains on their underwear, that would be a problem. They could go through the 7 clean days and still be staining. I have a lot of women who have staining issues who every month are getting through the 7 clean days and they're staining, but they're getting fine bedikot. So I think that it's important, like if women are frustrated and they're like, wow, like I'm still staining a little bit, to like remind them that even though they're still staining, they could actually start the process of getting to the mikvah. So that really sort of moves us to the topic of what is the difference between having a stain and a flow. So this is a very common question, and especially postpartum when people's bodies are like very erratic and not functioning normally, it's sometimes hard to figure out, well, like, is this something I'd consider a flow? Is it like my period? Is it lighter than my period? Like what actually am I seeing here? So some guidelines I gave you are consistency, like how long is it lasting for, like do you need to wear a panty liner? Can you wear one liner the whole day? If you wear one liner the whole day, then like that's probably staining, and you could probably start your 7 clean days. If you're changing your liner every 3 hours, that's more of a flow. So I think that understanding the line between the flow and the stain is really important, and I think it's useful to like, if women bring this up to you, to tell them that it's very helpful to like talk it out with someone and ask this question, and sometimes even show something. Like I've definitely looked at many liners and pads, and some women feel like it's kind of like grosser than showing a bedika cloth, but whatever, it's all the same. And it is very helpful to see what someone's talking about as opposed to just kind of like hearing and describing. So I think that's something that is good to keep in mind. The psychological factors of when a person can start the 7 clean days. So I think a lot of people are often like a little hesitant to start because they're not yet ready for intimacy. I don't know if you've discussed postpartum intimacy. Not really? Okay. So one thing that I think is a big misconception is that people think that if you go to the mikvah, you have to have intercourse. So that is not the case ever, meaning postpartum or in general. Having intercourse is always a decision that a couple can make. The halachic obligation or requirement or preference is that a woman go to the mikvah as soon as she can, but that doesn't mean that the night she goes to the mikvah, the couple have to have intercourse. So I think that is often something that calms people down. So I'm like, okay, I could go to the mikvah, like we could hug and kiss, and like we don't have to like start with things that might be painful or scary and things like that. So oftentimes women who are postpartum, because of where their hormones are, just like are not interested. There's just a lack of libido, which is very normal and common, and oftentimes scary to people. Like, why am I not interested? I was interested all the time when I was pregnant or before I was pregnant. So I think it's definitely important to validate that. Like, it could be hormones, it could be fatigue, it could be so many different factors. And I think that just encouraging people, like, okay, you can go to the mikvah and like whatever, you can take it slowly, I think is something that is often helpful. Some women who are finding that the area is very sensitive and dry are often helped by using like a water-based lubricant. You could use like any water-based lubricant on Shabbos. I always tell people postpartum, like, don't even try without a lubricant. Like, start with that because it could be painful. And I think that is often helpful. And if a person decides they're going to go to, like, if a person gets to the 7 clean days and goes to the mikvah, I think communicating expectations beforehand, okay, like, what are we doing after the mikvah, is important, so that way there's not, like, a clash when the woman comes home. Okay, so those are the psychological factors that are at play. Okay, so now let's talk about the third challenge, which is actually, like, getting through those 7 clean days during this time when our bodies are not exactly, like, running like clockwork. So the maximum requirement, like what ideally a woman should do is what she normally does, which is to do the hefsek tara, the initial check. Let's say like tonight is Wednesday night. Okay, so Wednesday before sundown, and then to do 2 bedikot a day. So Thursday through Wednesday, 2 a day, and then go to the mikvah Wednesday night after sundown. The standard protocol for postpartum is not to do the moch. Right, the moch is the bedika cloth that we put in between shkia and seder kochavim. So poskim say postpartum do not do the moch, like just don't do it, because that area is already so irritated that we don't want a woman to cut herself or to cause more irritation. So I think that's something that people don't necessarily realize. And also, in general, one is never supposed to cause themselves pain when they do a bedika, and especially postpartum. Like I always tell people, like, just go in as far as you can go, but like it shouldn't hurt you, and minimally you just need to go up to your first knuckle, which is pretty shallow and usually something that people are able to do. Okay. Yeah.
When you're saying postpartum, what do you
so I'm talking now like first time after having a baby, but this could also apply, and we'll get into that. Like let's say a person is ovulating, let's say they're not nursing, or they are nursing and they're ovulating and they're going to the mikvah. So this might apply like for the few months after she has a baby, depending on like how she's feeling and like how everything's doing with her body.
Have you ever seen a hesher for use of a lubricant on the bedika cloth?
Yes, we're going to get to that. Okay. Yeah. I think I even just wrote, did I skip that? Okay, yes. So I wrote, lubricate, yes. Lubricate with water. Like a person can do that without asking. If water is not doing it because it's not like slippery enough, so definitely to use lubricant on the bedika cloth is definitely okay and advised. Like we rather a person use lubricant than ends up cutting themselves with the bedika cloth. Yeah.
Now, is this also relevant for women anytime, not postpartum?
So, yes. So anyone who experiences pain with bediko is able to use. Anyone's really able to use water, meaning it. But like if you don't need it, then and lubricants are yes. People that have painful bediko should use lubricants. Like these halachot are not supposed to cause us like physical pain. Mm-hmm. So yeah, that definitely applies beyond postpartum. Okay, so now we get to a case where a woman has tried to get through the 7 clean days and she has to start again on day 4. She does a bedika and it's bad and she's like back to square one. Okay, so once a woman has tried to get through the 7 clean days once and she like has to start again, that's when we will often start applying certain leniencies. And that's because halacha basically views this as an emergency situation, and when we have a situation like this, we're allowed to rely on the b'diavad, like sort of the less ideal opinions that are in the Shulchan Aruch. So I'm going to tell you what they are, but these are situations definitely where people should ask, but just people should also know that there are like options out there. Like it's not like you're going to have to do 2 a day for the next 3 tries that you try to get through. Okay, so often what's recommended is shallow or badikot. Okay, that would be like first line of defense. The second thing would be reducing the number. Does you need handouts? Yeah. Reducing the number of badikot, so like knock down from 2 a day to 1 a day, depending on the situation. I would say like do the hefsek tahara is always required, do day 1, do day 4, and do day 7. Depending on the situation, that's would sort of figure out what makes sense. And then if there's a staining issue, like let's say a woman keeps staining, so we would advise her either to wear a panty liner, which according to most poskim is fine if a person sees a stain in a panty liner, even if it's a red stain. According to most, it would not make a person a nida. There are some poskim that say that since it's white, you need to wear a colored panty liner. That's not the psak that I follow, and I don't believe that the local poskim here follow that psak either. And other times we would just say like forget the panty liner with the white underwear, just wear colored underwear. Okay, so I had a case with a woman who she wasn't postpartum, but she had a different situation, and I gave her like a protocol that she should follow. I'm like, you don't have to ask again, you should just wear a liner for all the shiva nikim. And then she called me and she's like, you know what, the liner wasn't placed well and I got a stain. So I said, forget it. Like, I called the person that I consult with and he's like, yes, forget it, just tell her to wear colored underwear. So depending on the situation, we would apply certain leniencies. Those are the ones that are usually helpful. So that's after multiple attempts.
I want to clarify one thing. I think it's very important, especially in a mixed audience that we have here tonight, that the idea of us knowing this information is that if a woman expresses to us complications, I'm having a really hard time, this is so frustrating to me, the purpose of us hearing this is not that we would say, oh, by the way, I heard that you're totally permitted to wear black underwear. It's there is leniencies available.
Yes.
You need to ask your rabbi.
Right.
You need to ask your yoetzet. That to understand that there is room for flexibility, not that we are rendering that psak. I just feel it's
yeah, for sure, definitely. And like I think even like if I was giving this year to like a group of postpartum women, I would say you need to ask, but this is what's out there. So yeah, for sure. Okay, so next challenge is mikvah itself. Okay, so I've had like a lot of women text me like, I just had a baby. Can we like go over what I'm supposed to do? I'm nervous. The mikvah attendant's gonna think like, who is this lady? Like, how did she like? She has this baby. Like, is this baby even like halachically okay? Like, she doesn't know how to go to the mikvah. So I think sometimes, encouraging women to call someone or like look back at notes of like, what do you do to prepare for the mikvah? And like, when you go into the mikvah, what do you do? Like, after 9 months, you could forget and feel like a little bit unsure of yourself, like maybe like you did at the beginning when you were first married. I also think that sometimes it's helpful to like just like tell the mikvah attendant like, hi, I'm postpartum, so that you don't feel stupid if like you do something wrong or if you have like a question that you might feel silly asking. Also, I think one thing that's stressful for women going to the mikvah like the first time after and just with a nursing baby or with any baby that has like feedings around the clock is like logistically like, when should I plan to get there so that I can be back in time for the next feeding? So I think that as much as we want to respect the mikvah attendant's schedules, if a person has like an extenuating circumstance like that, like I think it's always just worth asking, like, would I be able to come and drop early? Would I be able to like come and drop late? If it's possible, great. And hopefully like, there could be some room for flexibility. And
don't bring the babies to the mikvah.
Right, and don't bring the baby with you. Have you seen?
Yes.
Oh, okay. I have not. Okay. Interesting. Okay. So other things that could come up are just like, if a person had a miscarriage, so like they might have questions about like, are steri strips a chatzitza, like can you go in with steri strips? Dissolvable stitches are fine. Like if a woman says I have dissolvable stitches, you can tell her, you can go to, like that is a case where I would say like you can inform her that is the halacha. She could go to the mikvah. Breast milk is like, is not a chatzitza unless it's dried, in which case you can just wipe it off. So I think these are sometimes things that are on people's minds when they're thinking about going. Okay, so challenge number 5. Help! I'm not ready to get pregnant again. Do I have to? Okay, so I'm not gonna address this topic in this setting just because it's a longer conversation. But I do think that it's important that women know that it's not like there's not a yes or no. It's a conversation with a couple and their halachic advisor. And I think that it's important for women like to know that it's not like, yes, you must get pregnant again right away, but that there's room for discussion.
In the case where somebody's just moved and they don't necessarily have somebody in the community that they can feel comfortable discussing something so personal with. I mean, I'm just using an example that like when I had my second, I moved, and the birth control that I was allowed to use from my previous Rav, like the new Rav said, oh no, you can't use that. And luckily I kind of like thought about it and I spoke to the old Rav and I kind of worked it out. But it did like leave me in a panic for like.
I hear that. Yeah, like what do you do? So I think if you're able to like. Sometimes if you move, you can still maintain a relationship with your old Rav. So I think like that's halachically fine. Like you could live, in a different location and still follow the psak of your old Rav.
Somebody who's never asked for that.
Right. So, I'm happy to recommend people to talk to. I think you could, I'm trying to think I'm happy to be a resource if you want to like send people or.
You might say like, would you like me to introduce you to the local Orthodox rabbi or
right.
the Orthodox website?
Yeah.
Would you like me to help you make that introduction? If that's what, again, I'm trying to think from where would this happen for us? How would that interaction work with us in community? We would be seen as an advocate. So working with someone to make that introduction, if for some reason they're not comfortable or haven't met.
Right, or like send an email and like CC like the person wanted to introduce you, like introductory email. But yeah, that could be definitely a challenging situation. I think this is often like an unspoken challenge of women, so I would just be sensitive to that. Like people don't always talk about it, but I think people do feel pressure, just what everyone else is doing or whatever their parents did or whatever it is. And I think it's important for people to know that like this is their life and they're the ones who are going to have to deal with whatever decision that they make. And I think that that's important to keep in mind. Okay, so contraceptives, okay? I think that's probably like the most common area of challenge. Okay, so the first thing that comes up often is that women often are starting contraceptives while they're trying to get through the 7 clean days. So if you are in the position to like recommend to women that they should not try to like get through the 7 clean days while they're starting the mini pill. Okay, that is a recipe for disaster often. I think it's a good idea to think about contraceptive options before you go to that 6-week visit and they're like, which contraceptive would you like? And they do take for granted that you're going to be on one, right? Like I remember I went for my first postpartum visit and there was like, information to fill out and it was like, which contraceptive choice are you thinking about? And I'm like, that's so interesting that it's not a choice. Like they're assuming. So I think it's good to think about in advance. If you're not in the frame of mind or someone hasn't thought about it, that's fine. If they're having an IUD inserted, I always recommend to go to the mikvah and then to have the insertion after, because an IUD insertion does cause staining or bleeding. That doesn't make a person a nida, but if they're trying to get through the 7 clean days and they're wearing white underwear and they have to do bedikot, then that creates a halachic problem of, okay, well, normally if a person has an IUD inserted and they see blood, that wouldn't make them a nida because that blood's attributed to the wound caused by the IUD. But if they're trying to get through the 7 clean days and they have to do internal checks and whatever they see in that bedikah cloth counts, then that creates a problem. So I would advise, hang on one second, to try to schedule that for after going to the mikvah. Yeah.
Okay, so I thought that it would make sense not to start a contraceptive, let's say, 5 weeks postpartum, 6 weeks postpartum, when you're like about to get to your 7 clean days, but rather at like, especially if it's a pill and not something inserted, at like 2-3 weeks when you're bleeding anyway, let it start. You're gonna just get all that blood out so that once you can go to the mikvah, then you can just.
Okay, great question. So a lot of doctors will not prescribe before the 6-week visit. If you could get your doctor to do that, like I know in Israel they will literally put an IUD in like right after you have a baby. But I feel like a lot of doctors here. Really? Okay, because I feel like most of the women that I've spoken to, like they're like, no, my doctor won't do it till after the postpartum checkup. So if you can start something like while you're bleeding and while your hormones are going haywire, that's great. But I definitely wouldn't start anything near the time that you're going to try to get through 7 clean days. If a person has to schedule an IUD insertion for whatever reason during the 7 clean days, so I think they should call, and we can sort of work around that. But it's definitely not ideal. The mini pill, deserves its own.
One comment. There are a lot who hold that IUD bleeding is still halachically nida, even if it's uterine blood.
So I think like most poskim hold that from the insertion, it's not because it's damaka. But I mean, are you possibly referring to IUD bleeding like
It's part of the
staining?
From ongoing bleeding, you can't really determine if it's a small period, if it's just general uterine bleeding.
I think like most poskim, and I could be wrong, hold that based on the Gemara about a woman saying like if I have wounds in my uterus, she's believed to say that she has wounds, and that bleeding that's attributed to non-hormonal causes does not make a person nida. I think that most poskim hold that if a doctor says you're going to bleed for 3 days or up to 5 days, you can attribute that blood to the insertion as long as it's not the time of like expecting your period. But I could be wrong. I'm sure we could find someone who says that, but I will look into it. Okay, so hormonal contraceptives, so also I would definitely recommend starting those after mikvah insertion. The mini pill especially has a very bad reputation for staining issues. So I think like get to the mikvah first. People often recommend if someone's nursing full time, and they don't want to get pregnant the first, let's just say like they're nervous, right? And they might be ovulating. They don't want to get pregnant that first night after going to the mikvah, but they're not on anything. So spermicide is a good backup method if you're nursing. Spermicide, I put in the back of your packet like the CDC guidelines for contraceptives and how effective they are. I think it's the last page. So spermicide is generally not the most effective method, but in combination with like nursing around the clock, it is like a good backup plan. So a lot of women like will use that for like a few nights, let's say, until they start on something else. So that's just, I think, good to know about. Okay, any questions about that? Okay. All right. So the other thing is that I think doctors often like just give a prescription like here's the mini pill, unless you're getting an IUD, and like people think that's the only option. Okay, so a lot of women who have staining issues on the mini pill and call me like crying like month after month, I'll say to them like have you explored other options with your doctor, because there really are other options. A lot of doctors will prescribe a pill that has estrogen and progesterone once the milk supply is well established. The reason that they give the mini pill is because we don't want the estrogen to interfere with milk production. But once a person is like on a regular nursing schedule and the baby's getting enough food and like everything is kind of working, doctors will prescribe the combined pill. I think that people just don't know about it, but there's definitely been a lot written about it, a number of articles written about it, and I think doctors will prescribe it. I think they just like their first go-to is like, oh, let's put you on the mini pill. But that is definitely an option. Another misconception is that IUDs are only for people who want to have like big spaces between their kids. I think people think that like an IUD is like you have this thing inserted and like then it's like a big production to get it in and get it out. And since it's like good for 5 or 10 years, it sounds like it's only for someone who wants to have it in for 5 or 10 years. So truth be told, right, an IUD takes like 5 minutes to put in and 10 minutes to take out. And I think that it's, if you have a conversation with someone about this, it's good to like let them know that an IUD is a real option. Women who don't tolerate hormones, there are other options for them. Halachically, like we prefer IUDs or hormones over other methods, but there are definitely women who, because of their family medical histories or because like of their own tolerance of hormones and their side effects, like don't want to have anything to do with hormones, and diaphragmless spermicide is an option. It's not foolproof because there's a lot of like room for messing up, right? Because it's dependent on what you do, if you put it in right, if you wait enough time. But that's an option. Spermicide alone, some people are willing to use if like they don't want to get pregnant, but like if they did, they would like be okay with it, right? And some people use the fertility awareness method, which I gave you a little cheat sheet. So there are all sorts of like home kits people could buy in the drugstore in that, family planning aisle. And one method is using basal body temperature to predict when you're ovulating. So you sit with a thermometer under your tongue like every morning for a number of days, like before you get out of bed, and you can predict when you're ovulating. People often measure their cervical mucus. The cervical mucus changes throughout your cycle, and you can predict when you're ovulating. I had one woman who had a number of children, and she said she absolutely did not want to get pregnant. So we went through different options. We went through pills, no pills. She doesn't want to do hormones. So I said, okay, what about the Paragard IUD, which doesn't have any hormones? She said, no, I had a friend who got pregnant on the Paragard. So I said, okay. It is 99% effective, but okay, fine. After all the options, she decided that she thought the best option for her was fertility awareness method. I tried to explain that it was the least effective option, and she started her conversation with saying, I really don't want to get pregnant, but that's what she chose. So I think it's good for people to know that there are options out there. She's not pregnant yet, so I don't know. Not that I know of.
The thing with that is, aren't we usually the most fertile right when we're going to the mikvah?
Yes. So she chose that method, and then there were all sorts of follow-up questions about, okay, so we're not going to be together, when I go to the mikvah and the 2 nights after, are there any things that my husband and I can do, or that anything my husband can do for himself? So that was a whole other interesting discussion and process of questions. So that they chose that. I mean, that's what they opted for, and as far as I know, she's not pregnant, but I told her, I'm like this,
If a woman had a normal cycle, 28 days, and they really had a period just for 5 days, and then 7-day clean cycle, and then you're probably fertile for, let's say 4, then they only have about 8 days.
Right, well, I mean, no, I think you should have 2, well, they would have 10 days, let's say, or 11 days. I think it's very risky. I mean, it is very risky, but people do it. Okay, so the Mirena IUD has its own slide because it has its own challenges. So the Mirena IUD or other hormonal IUDs have this infamous 3 to 6 month adjustment period. Some people have no issues. Other people are in the mikveh every other week, are calling every other week because they're staining, they're bleeding again. I think it's important to know the difference between staining and flowing for the Mirena, and that's we spoke about before. Are you bleeding heavy like your period, or are you just seeing something in your underwear? That's important to keep in mind. And there are doctors that will prescribe an oral contraceptive for that first 2 or 3 months to get a person over the hump of the adjustment, so that way they don't have to deal with all of the staining issues. So that's something that people don't really know about, but it's definitely something to ask about. I mean, obviously people don't want to be on double doses of hormones, but the hormones from the Mirena IUD are very localized, and they don't go through your whole system, so it's not like you're taking 2 pills a day of something, right? You're just taking oral dose of something, a low dose oral pill, and having the Mirena IUD. So that's something that people have found to be really helpful in avoiding the staining issues if they want to be on the Mirena for the benefits of not getting your period or having very late periods, or whatever other benefits that it offers. Okay, so the Paragard IUD is a great option for women who don't like hormones. The copper IUD. Okay, I think Paragard is the only brand that markets it now. Women who have heavy periods are advised to stay away from the Paragard because the Paragard does have a reputation for longer and heavier periods and more cramping. Some women do adjust to it, and some don't. And some people are willing to be okay, I like just not having hormones. And some people decide that they don't like having, an 8-day period and, having 15 days, 16 days apart. And then, I think for women with longer cycles, it's not so bad because, okay, you have 15 days apart, but then you have 17 days together, right? If you have short cycles, the Paragard IUD, if it's going to give you a heavier, longer period, might not be such a good option. But I think the most important thing is that, I know women often talk about contraceptives. It's important that people know that there are many different things out there, and they should be educated consumers and advocate for themselves and ask their doctors, okay, this is not working for me. What else? What other options do you think might be good for me? Okay. So challenge number 7 is I'm bleeding again. Okay, so this often happens, right? Even after the first time someone goes to the mikvah postpartum, like all of a sudden, like they're just bleeding again, like when they're not supposed to. They're on a pill and they're just bleeding during the non-placebo week, or they have an IUD in and they're just like bleeding, like they got their period. They go into the mikvah yesterday, right, and like they're seeing something the next day. That is a pretty frequent complaint that I hear. So, important to keep in mind that not all blood makes a person a nida, as we spoke about. If it's a flow, it has to meet certain requirements, and if it's a stain, it has to meet certain requirements to make a person a nida. So I think that, people often freak out when they see anything, but it's important to keep in mind that not all blood, will send you back into the 7 clean days and send you back to the mikvah. Okay, so, just for a flow, so it has to be a problematic color. The source of blood has to be uterine, okay? So if you know that you have a hemorrhoid, right, so that might show up in a person's underwear, but that, if they could say, I have hemorrhoids, and this blood looks like it's from a hemorrhoid, so that would help them out. They wouldn't have to go to the mikveh for that. And the trigger needs to be hormonal. Okay, so if a person has a uterine polyp or something, or a cyst, and they know that they have a cyst and they feel like the cyst is ruptured. I just had a woman call me with this, right? So that would show up as blood in a person's underwear, but that wouldn't necessarily make them nida if they could verify that it's from the cyst and not from, from ovulation or from some hormonal cause. So that is definitely key. I think the partner between medicine and halacha is important here, and using doctors to get information is really important in terms of figuring things out and making all of this whole time period less frustrating for people.
What about blood during the examination?
So that's cervical. I always tell people not to look, but during a regular exam, so for a pap smear, so that they're not going past the cervix, and that part of the cervix is not, there's a discussion about the status of the cervix in halacha, is a part of the uterus or not. Anyway, it's from scraping the uterus, so it wouldn't be nida.
It's not
Yeah, they might, right. And then for an internal exam, I just tell people not to look at the doctor's hand on the glove, because there's no need to look. And that is going inside the uterus, right? They're feeling when they stick their hand, they're feeling your fallopian tubes.
They're not. They're not going past the cervix.
Sorry, they're not going past the cervix. But they are inserting their fingers in, which when they take their hands out, it's like a badika.
Yeah, but it's
right.
not. But it still would never be uterine.
Right, but the problem is it would present a halachic problem if, in the same way that if you inserted your finger, right? When a person does a badika, right, they insert their finger in, so anything that shows up on the badika cloth counts, because of the fact that we have this whole idea of hargasha, that while the person was inserting their finger, they had this sensation, which according to the Gemara makes a person a nida. So that's why whenever a person does a badika, whatever they see counts, because one of the biblical requirements for nida is hargasha, that you have to have this sensation. Now, we don't feel the sensation nowadays, but we assume that the sensation was masked by something else, right? So that's why when a person does a badika, whatever they see counts, because perhaps they had this hargasha, which would make a person a nida, but they didn't feel it while they were inserting their finger. Right. So in the same way... So, yes, because it's on a person's hand. In the same way if you would stick your finger up and see it on your finger.
Yeah, but if I took sorry to get technical, if I took a black cloth, for whatever reason, stuck a black cloth up vaginally and pulled it out, that would, even if there was something on, it would be on a cloth that was non-makabel tumah because of the color. Or something rubber, something that is not makabel tumah.
Right, so anytime you have anything internal, like a diaphragm, if you pulled out a diaphragm and you saw, or a new ring, and you saw blood in it, that would be a problem, because even though it's not makabel tumah, the category of being makabel tumah, susceptible to ritual impurity, is a rabbinic category. When we talk about hargasha, we're talking on a biblical level. So even though it doesn't meet the rabbinic requirements, on a biblical level, a person is a nida if they had this hargasha. So in the cases where you're inserting something internal, there's a suffix. Like maybe you had this hargasha, which would throw you into nida. So that's why no matter what you insert, if you saw blood in it, it would be a problem. Right? In the same way.
How too much is something that's external. Whenever it's internal, there's no.
Right.
You're just saying, don't
Right.
look, and I don't know.
Right. Don't look. So I just tell people don't look at the glove because, like, if you saw something, that would be a problem.
So
Okay.
if the doctor says, oh, you're bleeding a little bit, if you're not seeing it, then it's...
Can you ask them? not to
Yeah.
tell you?
Yeah. I often tell people just ask them not to tell you. Just tell them that you don't want to know if you're bleeding. You don't have to
I
know.
was always told to ask, just make sure that the only thing that I would see would be something that was cervical.
Mm-hmm.
If it's non-uterine blood, why would it be a problem? The doctor says.
If the doctor verifies that the blood is not uterine, right. If they tell you this because they know from the exam, so then that's different, right? But if they just pull their hand out and you see it and
Something
you
like,
don't
there
know.
would be no reason that a doctor would go beyond the cervix unless there was a procedure that they were doing. Like if they were going in for a fibroid or they're going in for
Right.
a biopsy, yes, but not that.
Right, but when you do exactly. But when you do a badika, you're not going past the cervix either, right? And whatever you see counts, right? Okay. I'm happy to clarify more after. Okay.
Sorry, it's
No, it's totally fine. Feel free to ask. Okay, so for a stain, right? So there are different requirements for a stain to make a person anida. It has to be on something white. It has to be or on part of your body where blood could have dropped, right? So your shoulder wouldn't be a good option. Your toe, your hands, like any area of your body that could have touched that area and blood could have gotten on it would be a candidate. It has to be, as we spoke about, on something that's makabel tama. So according to most poskim, a pant liner or a pad is not makabel tama. Cotton underwear is. The crotch of black underwear that has the white fibers woven in, that is. It has to be a problematic color. Okay, if it's brown, according to most poskim, brown is okay. So if it was black or pink or red, that would be a problem. The problematic color has to be a certain size, and it has to not be attributable to another source. Okay, so when a woman is postpartum, right, if you look at the slide here, right, there are a lot of different areas that could be bleeding, right? She could have hemorrhoids, she could have a UTI, she could have just like vaginal bleeding because the area is sensitive, right? So there are a lot of different places to attribute the blood to, which is why it's important to keep all these things in mind, especially during the postpartum period when there's just so much going on and so many places that the blood could be coming from that might not make a woman anida. So I just gave you a list of like hormonal and non-hormonal causes that could be causes of bleeding here. Okay, so the next slide is kind of just like a to-do. If you have unexpected bleeding, determine if you're staining or flowing, figure out what the cause might be, consult with a doctor, think about contraceptive options, and I will send you this pamphlet that has like tips for getting through the very difficult postpartum period. Okay, challenge 8, painful intercourse. Not spoken about so much, very common. A lot of people find that intercourse after the first time is like more painful than the first time they ever had intercourse. And some women find that it's a recurring issue. It's not just the first time after going to the mikvah, but it's like the first few times, and then they get into the cycle of like, well, it hurt last time, so I don't want to go to the mikvah, I don't want to have intercourse, I don't want to try again, and then it creates a dynamic between the couple of like the husband wants to, the woman doesn't want to, and it could be a very challenging cycle. So definitely lubrication is recommended, and if a person sees that this is persisting for like a while, there are a lot of over-the-counter medications that a person can use so that the vaginal lining is less like sensitive and intercourse will be more comfortable. Sometimes people do have like more serious issues postpartum, and I think the first step is always to contact the doctor, and then they could say like, okay, come in for an exam, let's see if there's a pelvic floor issue, and they could sort of take it from there. I think you heard from the pelvic floor. Okay, great. So yeah, I think it's just good to remind people that that their doctor is a resource and can help them with these challenges. Okay, so fasting, I don't know if you'll encounter this, but the answer isn't, yeah.
Sorry, I just want to say about the doctor being a resource. They are, but only to a point, because they don't care about staining.
Right.
It's not a medical issue to them. So they don't really understand or empathize with you if you're calling because you keep saying it, because they'll be like, there's nothing wrong with the birth control or with your body or this or that.
Sometimes they do. Like my OB
Some
knows a lot
doctors-
about mikvah.
So
and
some
it's like
doctors do,
very
but some don't.
Some don't, right? Okay, so that's a good point, right? Some do and some don't. I actually once gave like a primer to an OB. Someone was having frustrations with their like IVF clinic, and they were like, "Can you talk to my doctor? They want to talk to you." So I gave them like a whole like spiel, like. And the person ended up leaving their practice because they were so frustrated. But I think doctors don't always understand. And like when a woman is staining, they're like, okay, great, you're staining. So does everyone else who's on this pill. But I think there are some doctors that do. I think it's important to like advocate as best as a person can for themselves. And like if you feel like your doctor is not getting it, like there's always the option of switching doctors, right. I do get a lot of calls that I feel like could have been discussed with a doctor, but the person's doctor is not like giving them the information. So, I definitely.
Doctors who are sensitive to these issues, should we?
I don't know if I would feel comfortable recommending certain doctors, but I think like if you like ask around, I don't know. I kind of feel weird like advocating for certain people or like, but yeah, you can ask Alit who she likes. Okay.
And if you want a doctor, he happens to know about this stuff and is very sensitive to it.
Okay, great.
I feel like my doctor's never
Yeah,
done the pelvic floor thing, so.
Your doctor, say again?
I mean, I've been in different states everywhere, but doctors don't know about the pelvic.
Yeah, so a lot of them don't know, so I'm glad you heard from Hina because, yeah. Okay, so the last issue is pumping on Shabbos. That could be a frustrating one. Women are experiencing pain and engorgement. I get this call a lot on Friday afternoon, like, help, I just had a baby, like, I'm in pain, can I use a pump on Shabbos? So I think it's, here are some guidelines. I think it's good that people should know that they could put the pump on a Shabbos clock. If they can't do that, they could use a hand pump. If they can't do that, they could use their hands. Like a lot of time, it's very painful, like the first few weeks after having a baby, right, when your milk is coming in and everything's adjusting. Unfortunately, halakhically, you do need to discard the milk, which is hard and frustrating, and everyone hates doing it. There are sometimes extenuating circumstances, so I think it's always important that a person who is in the situation ask a question so that they're not stuck, without an appropriate answer for themselves.
I was allowed to keep my milk for the baby because he was a preemie.
Okay, right, so that's a perfect example, right, where like, it's so good that you asked the
I
question.
was allowed to have someone else turn
The pump on for you, right? Okay, yeah. So it's always good to ask. So I just gave you a list of frequently asked questions. Like if you go on the Nishmat website, you could find a million more. But there are lots of questions about this, and hopefully I gave you a sense of the challenges that come up. And if you have any follow-up questions at any point, you could feel free to contact me or send your people my way, and I'm happy to help.
Thank you. Thank you. Anytime. You can press stop. I think there's a way to press stop.
You want to show me how to press stop?
Do you teach Kala teachers?
I don't
I
teach.
feel like a lot of this information, like when you go to Kala classes, they don't tell you half of this stuff. What is it? It is recording. Thank you so
Okay.
much.
Anyway, hi. I, at the very last minute, made out some sheets because I thought I should have sheets. They don't say that much, but they do cover what I'm going to be talking about, and just so I thought you guys can take notes on them. So there's probably 15 there. Just a little background. I'm a certified nurse midwife in private practice. I've been a midwife for 20 years. And I have practiced in a lot of the hospitals in the area. I do hospital birth only. And I spent 10 years at Lankenau, and I'm fairly familiar with at least the mainline hospitals and how things go down there, having been there for a long time. And now I deliver my babies at Einstein Montgomery out in East Norriton. And the one thing I did want to say when people were saying, what do you do if your doctor doesn't listen to you, is go to a midwife next time. If any of you don't know, certified nurse midwives are independent providers, masters prepared, and we're licensed by the state to do independent practice. Einstein Montgomery, we have to have a collaborating physician agreement with a group of physicians who agree to do our C-sections and the things that we don't do that's not in our scope of practice. I have 15 collaborating physicians over at Einstein Montgomery, which is a very lovely birth-centered, baby-friendly hospital to deliver at. It's I think, having been to most of them around here now, very innovative, very supportive of whatever sort of pictures they would get in a birth, skin to skin, and lactation consultants, and people in the room can contest to it. We have a great team and a great staff, and really pushing towards real baby-friendly and mom-friendly policies. So if you encounter someone who had a really terrible time in the mainline system and feels like they can travel or are somewhere near out there, we have people traveling from all over to come to us. It's a really great place to have a baby. I tried to talking to Eliza and talking to Devorah, tried to figure out what you guys would need from me, and I'm very conversational and I'm fine with answering any kind of clinical questions that you have. We did talk about sort of what you may encounter, things that would happen at a birth that could affect people postpartum. And I, troubleshooting with Devorah, put together this list. It's by no means extensive, and I didn't go into the nitty-gritty details. These are big sort of concepts that I see, at least in my practice, when people come in postpartum, or immediately when I see them postpartum in the hospital, what people sort of rocks their world a little bit for what they didn't imagine their birth would be like. As you can probably imagine, midwife patients are a self-selected group of patients who are looking for a certain kind of birth experience. They're usually either super educated and have looked into all their choices and think this is the best choice for them, or they had a pretty terrible experience that first time around with an OB. We get some of that backlash, people who are coming to us because they didn't like what happened to them last time and they want more control or say. Some people do it for religious reasons. They want to guarantee they have a woman and a modesty and want more woman-centered and somebody will listen to them, things like that. So the complaints or the concerns that or when I think about unintended aspects of birth, that these are some of the things that come up for my patients. There are certainly more things that you may come up to say to me, like, what about this, that didn't even occur to me. But my patients will be most sort of, what they don't expect is a C-section that they didn't expect, or anesthesia that they hear, oh, epidural is going to work perfectly, you're not going to feel a thing, and it turns out that's not true. Or they feel really bad afterwards, and it's because they bled like crazy, or there is a lot of damage downstairs that they're really upset about. So those are the things I put there, certainly. So I'm going to touch on those and just talk about what I wrote there. And then anything else you want to talk, I'm the cleanup batter. So if there's any clinical or medical stuff that came up that you're just sort of like, what does this mean, or whatever it is, I'm happy to sort of talk from my clinical experience. Is there an extra one of those? Because I actually didn't leave myself one. Cool, thank you. All right. Does that sound okay? I mean, I talk fast. I'm from New York, so interrupt. I'm sure this crowd is okay with that, but if you need me to stop. So, in my practice, 30% of women get epidurals. This is a difference also between a midwife practice and a straight OB practice. And that's not because I have a bias against epidurals. For any reason, I actually deliver in a hospital so women can have those options. But again, women who choose midwives tend to choose them because they're looking for an unmedicated birth. Most of the time. I have plenty of patients who say to me, I want a midwife, but you better hook me up with the epidural the minute I walk in the door, which is completely fine with me. Those women who want an epidural and actually go too quickly, or they show up 9 centimeters and can't get an epidural, have all this stuff, but I wanted it. And I'm like, you went fast, you went too fast, I can't help it. So there are a couple things around anesthesia that you might hear about afterwards that people are upset about and then can affect their postpartum course. People do tend to think that epidurals will just make you not feel a thing. And now anesthesiologists are actually backing off of that a little bit. Everyone knows what an epidural is here, right? Obviously. Okay. So they used to sort of pitch themselves as though we can give you pain-free childbirth. And then now they're actually, when they talk about it, they're like, well, this isn't going to take all your pain away, and you may still feel things. So there's a disconnect between, I think, what women think is going to happen and what actually happens. And that can be anything from feeling nothing and laying like this and not being able to move and affecting the way they push and get the baby out, or that they feel too much. So what happens a lot is something called a window in anesthesia, and maybe some of you have even experienced it, which is that you get an epidural and there's just like one stinking spot that doesn't take. And it's the way the catheter goes in and it gets kinked and you keep trying and you get number and number everywhere else, but there's you feel everything right there. And it's painful because now it's all concentrated in one place. And that leads to a lot of anxiety because you keep thinking I'm going to get pain relief, and then it's still painful. What's a bigger deal is when people who have epidurals and have epidurals for a long time, and it ends up that they go in for a C-section because whatever, the labor doesn't progress, the baby's unhappy, and they have a C-section with epidurals in place. So if you already have an epidural going on, usually they just dose that up a little more to give you enough anesthesia for surgery. But epidurals are not the best anesthesia for surgery. And so you may meet women, and this happens a lot, that women who have had long drawn-out labors and then they end up with a C-section will tell you, I felt things. And you may have experienced this. And it's just because it's just not the best, and they don't want to take an epidural out and give you a spinal and keep manipulating your back, right? So I've seen that happen. Luckily, it doesn't happen that much. I've seen that happen, and if they can't get a woman comfortable, they actually have to put her to sleep. Again, this is a whole sort of a snowball, right? And then they end up being asleep for their delivery, or they dose them up so much to try to get the anesthesia, then they get nauseous, then they give them drugs for nausea, and then they pass out, and so they miss the whole birth. So really, and a little bit of, a lack of anesthesia here can lead to a whole bunch of stuff afterwards. The biggest thing is PTSD. So I have a patient right now who had ineffective anesthesia at her C-section the last time, not with us, with a different provider, and she is going to a therapist right now, and she has true PTSD about it. She remembers the mask over her face. She had an allergy to the adhesive, so she's having she has a lot going on around it, and it all stemmed back from that she remembers you had surgery and you felt it. So you may encounter that, and that's just something they have to sort of work through that. And it doesn't mean that next time it's going to happen, and certainly the next time they have a baby, it's important to tell them that they can talk to anesthesia about that. Yeah.
So this happened to me. This is terrible. But what helped me, because I had PTS, I could not imagine ever. And then, so my second one, of course, I went to a midwife and a doula, and I did hypnobirthing, and that's what helped, the hypnobirthing.
So you didn't end up with an epidural the second time?
Well, I needed to. I was already pushing. It was great. But then meconium, emergency, I had a uterus rupture.
Oh my gosh.
The second one, it was a 5-hour surgery. That was a whole nother.
Oh my gosh.
But I had post-traumatic stress disorder and depression, I think, after my first one, because it's not what I expected. And the doctors took advantage of me. Every right and left, they told me I'm not going to do this, and then I did it. But the second time, the midwife handled it so well and let me make all my decisions. Even after a 5-hour surgery, I almost died, whatever. I had no...
Right. It's certainly, it certainly is. I think the way people talk to you or handle it has a lot. I've seen this. People can go through different experiences, but the way they feel, how much control they had, and how much they think people ignoring them during it or not paying attention to what they're saying. I'm feeling you cutting me right now. I feel this right now, and people ignoring them. You can imagine how that would be. Yeah. Wow, walking and talking after uterine rupture. That's impressive.
Yeah. And the baby was okay.
Yeah.
But the hypnobirthing.
So there are other options.
That really helped.
Right. That's a great thing. That they're going to be very focused. People are very focused immediately postpartum. Like, I'm never having another kid. I can't. And certainly when they get pregnant the next time, it all comes back. But there are lots of options besides epidurals, and that it really is a fluke when they don't get coverage. It doesn't happen a lot, and so there is some reassurance you can provide that you tell the anesthesiologist, tell your provider that last time it didn't work, like we need to do something better, and find your voice. A lot of people who go through this experience, as you probably know, imagine that they're going to actually have a say in what goes on, and it'll be a discussion, and there'll be partners in their care. And most of the time, unfortunately, the way that our healthcare system is set up, the way the hospitals and birth is set up, certainly in Philadelphia, but in the United States, women don't really have a voice, right? So certainly encouraging women and hearing what they have to say, and encouraging them that they actually next time can take a lot of that into their own hands. That's how they end up with us. Okay, so does that make sense? The anesthesia thing, yeah. So unexpected C-section, sort of related to this stuff. Obviously, anesthesia, people can have C-sections for all sorts of reasons across the board. Fetal problems, mom problems. They can be sort of a C-section that happens because the labor just is slowing down and then doesn't get anywhere. You're stuck at 5 centimeters, you're stuck at 7 centimeters, whatever it is, and so it's not emergent. And it's nice and calm, and there's a lot of explaining, and people understand why. And then there can be the baby's not happy, we need to go now, which is a lot scarier. Again, same issues, I wasn't expecting that to happen. I never thought that could happen if I went to this doctor. My patients think, what do you mean I'm having a C-section? I went to a midwife, as if we can change how things work, you know. And so again, it's the PTSD. You'll hear these stories. And women really, and they come to my office still talking about it, they just need to be heard. As you probably learned here, that it's just listening to what they have to say and saying, yeah, that stinks, you know. And that as we all know, once a C-section is not always a C-section. If people are thinking about a vaginal delivery, that most of the time, a vaginal delivery after C-section is a possibility. We do a lot of VBACs in our practice. Sometimes there are complications to VBACs. But I think that the best we can do is just listen to women and hear how they felt powerless. I mean, that's most of the time people feel sort of powerless in those situations. There's also a lot, I'm sure you guys went over this, disappointment. People blame themselves. I find that most of my patients who have an unintended outcome or something happens they didn't expect, they always blame themselves. The woman, it's our fault. I should have done this. I should have ran more. I should have done more exercise. I didn't squat enough. You know, I didn't squat enough is a big one. I didn't eat enough. I ate too much. You know, like as if we have any control over what really happens. And I try to emphasize that there's you, and then there's a passenger the passenger has their own story, right? They get themselves in all sorts of situations, right? But women tend to sort of blame themselves and then have guilt on top of that. All right, coming off of the blood discussion you just had, this is more likely, like postpartum hemorrhage is a big thing. I don't know how much you guys have talked about it at all. Okay, postpartum hemorrhage is, you're going to see a lot because the way that OBs practice, it happens. Postpartum hemorrhage is defined as more than 500 milliliters of blood loss after delivery, and 500 milliliters is a half a liter. Like those liter bags of fluid, a liter Coke bottle, like 2 full cups of, for a vaginal delivery. For a C-section, you lose that much, but they're giving you tons of fluid during it. C-section, you lose like 1,000 cc's of blood. But anyway, a vaginal delivery, after the baby's born, then sometime within the next half hour, the placenta detaches because the uterus contracts and the placenta detaches and the placenta comes out. And what's supposed to happen is after the placenta comes out, the uterus has a couple of strong contractions and contracts down and stops that open wound from bleeding. So the placenta rips off. It's an organ that women create, and it's an organ inside your body, and it basically tears off. And the spot where it tears off from uterus is an open wound that's just like your knee. And it's bleeding. And the way, if you were bleeding, you'd put pressure on the wound to get it to stop. So what happens is the uterus contracts, the fibers contract, and that shuts off the little capillaries from bleeding. So that's so that women don't bleed to death. There are lots of instances where that open wound will keep bleeding. Most often it happens because the uterus doesn't effectively contract afterwards, or takes a really long time to contract. And that happens when women have really long labors, so induced labors that take 2 or 3 days to get the baby out, or just a long drawn out labor where the uterus, by the time the baby's out, the uterus is just done. It is like it just doesn't work anymore. The placenta comes out and it doesn't do anything. And it's called a boggy uterus, so it doesn't firm up, it doesn't tone up. You know that afterwards where they press your belly really hard and they rub on it and you're screaming your head off? That's to get the uterus to contract, because otherwise you bleed and bleed and bleed and bleed. The other reason, so long drawn out labors, women who have had a lot of children, so 4, 5 and beyond children, are at much higher risk for hemorrhage because their uteruses are bigger and floppier and boggier and kind of just more tired and more stretched out. And those women, so women with history of multiple pregnancies are more at risk for hemorrhage. Also very fast labors where the babies just come flying out, those women are at risk for hemorrhage. And then women who, whose placentas get stuck in there and don't come out, and you have to go in and scoop them out. Also, sort of your uterus kind of gets upset about that. So when women bleed a lot after delivery, women can tolerate a lot of blood loss after delivery. And if you remember, if any of you were pregnant, when we check your iron level and see if you're anemic or not, we try to keep you at a certain level. It's because we know you're going to bleed during delivery, and we want you to be able to tolerate that and have a reserve. If you go in anemic, which a lot of women we see are, if you go into delivery anemic already and you lose blood, everybody loses blood after delivery. If you lose a lot, you can get into that really sort of dangerous mode, and you end up either symptomatic of the blood loss. If you're symptomatic enough, you get a blood transfusion. We try not to do blood transfusions just because people don't like them anymore. People have reactions to blood transfusions. So, and if you get a blood transfusion, you feel really great afterwards. So most women don't. So most women go home after they've had a big blood loss and feel terrible, on top of the sleep deprivation and feeling terrible from having a delivery. So you're exhausted, hard to get out of bed, dizzy, lightheaded, racing heart, all of that. So that stinks. On top of which, it's hard to breastfeed your baby. Because in your body, when you lose enough blood, your body has to sort of prioritize where it's going to get the rest of your blood, where does it need to go? And the breasts are not even on the top 15 list, right? You've got to go to your brain and your heart and things like that to actually. So women with postpartum hemorrhage have a delayed onset of lactogenesis. I see this a lot. And it's hard because then their milk doesn't come in, then they go to the doctor says the baby's losing weight, they get into that whole cycle that you get into. You can't nurse, baby needs formula, Now there's something wrong with them. I can't feed my baby, it's my fault. Plus you're exhausted, you feel terrible, you can barely stand up. So that's a really tricky one. Again, if she has a transfusion, she feels great. If she doesn't have a transfusion, she has a long time till you're going to feel better. We send them home with iron supplements and tell them to eat a lot of meat and dark green leafies and things like that. But that can take a couple of weeks to feel better. So you may see that.
I had a friend who was convinced she was gonna die too, just because of all the panic that was going on. She's having post-traumatic stress from that because.
Well, when you see when you see 15 people run into a room in your delivery or after your delivery, it's like
she thought she was never gonna meet her baby and die right there at the table. So that's another horrifying.
Yes, yet another PTSD.
I'm just curious, what are some of the medical responses to get that uterus to shut down?
So what happens is the placenta comes out, we go like this and hope your uterus firms up. If it does, great. If you keep bleeding, brisk bleeding, so then a woman is we're either going to go in there to see if there's a piece of placenta still in there. Sometimes just to stop the bleeding emergently, there's something we do which feels horrible, is to put a hand in the uterus inside and out and massage the uterus to get it to contract. But mostly medicines. So that's until the nurse can get all the medicines you need, I might be doing this to get it to stop. And then Pitocin. We use Pitocin either injected or in the IV. We also, and then there are two other. It keeps ramping up. We have another medicine, Cytotec, and then there's another medicine called Pemabate. And then if the woman is still bleeding, she can go back to an OR because maybe she needs a DNC. Maybe there's a piece of placenta in there, something like that. I mean, luckily, I've only seen one in 20 years, one hysterectomy.
Yeah, so, and what circumstances would it be that they would result in a hysterectomy?
They can't get the bleeding to stop. So, I mean, there's uterine artery embolization. I mean, they either kind of clamp the uterine an artery leading to the uterus to get it to stop, and if they can't get to it or whatever, then it's very unusual. People really try not to. This was on a woman this was her second kid.
I'm dealing with this a lot.
Yeah.
We're dealing with this a lot.
Well, if you have grand multips, right? I mean, if this population is
some of them are after their second.
Yeah.
Do you think it's malpractice
No.
They really try. I mean, it is one of those. It is, and plus the
surgery trying to
right.
That uterus. I mean, this was not an easy decision for any of these physicians.
Yeah.
So the implications.
It's terrible. I mean, the physicians feel horrible.
These women were fairly aware, but they also felt like they were dying. They knew that they were dying.
Right. I mean, you see the look on and they consent you. I mean, when you go back to an OR, they're going to saying, if we can't get this stopped, we might have to take your uterus out. And what are you going to say? No, please don't do that. I mean, you want to save my life. You get it. It's pretty unusual, but that's
It's the population that I work with specifically.
Yikes.
Is a uterus abruption also a uterus abruption would cause?
It's a placental abruption or a uterine rupture. Right, so an abruption. So placental abruption is when your placenta peels away, detaches from your uterus before the baby's out. Right. So the placenta keeps the baby alive. The uterus the placenta can detach, which is life-threatening to the baby and to you because you start bleeding. That's during labor.
That was a different birth. I know they told me. I know. They told me I had a uterus.
I'm freaking out. I know.
A uterus abruption. That's not anything.
A rupture. The uterine rupture.
That was not a uterus rupture, that was something else.
A uterine rupture is when your uterus explodes.
Right.
It tears
No, this
open.
doesn't have- No, so then this is a placenta, right?
Placenta. Well, so what happens? Uterine ruptures happens most often. Again, I've had one in 20 years. If you've had a C-section before, so you have a C-section, you have a scar, so there's a weak area of your uterus, and then you have another baby, and you go in labor again, and that scar, for whatever reason, that scar tissue starts giving, getting thinner and thinner, and then it opens like a little zipper almost. It opens up. If it opens up, so if you have a scar that just opens, right, it starts bleeding, so that's you are bleeding internally, and the baby is losing oxygen, because your oxygen drops, right? So that is the biggest risk of VBAC. It has a less than 1% chance of it happening. It's life-threatening. Yeah. I gotta leave, this crowd is like scary. Uterine rupture. So what happens is we do everything we can so that it doesn't happen. And then the way you know it's happening, there's two ways you know it's happening. It's either, and I tell my patients this who have VBACs, I was like, there's two things. You either go ow, 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 or your baby goes boom, 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 the heartbeat, right? Well, you're going to go ow, ow, ow most of your labor anyway. So we monitor, so VBACs are monitored all the time, the fetal monitor all the time, as opposed to if you don't have a VBAC, you're just walking around without the monitor on. And any census that's happening is it's a stat section, run them back and get the baby out before and show the mom up before anything happens. So it's a pretty urgent situation. Again, it's supposedly uterine ruptures happen to women who haven't had a scar. There is a risk for all of us who get pregnant and go into labor that your uterus can just rip open. I've never seen that happen, but there is a background risk of that. VBACs have a higher rate. So, and there were, before they put sort of rules on how to induce women who've had previous C-sections, there were much more uterine ruptures because they were inducing women with all these prostaglandins and things, Cervidil, stuff like that we use to induce that we don't use anymore because they're not controllable and they're unsafe to use for a woman with a uterine scar. So, about 30% of my practice is a VBACs, and we've had a couple with the VBACs. It's not like their babies aren't coming out. So they get stuck at 6 centimeters, they get stuck at 9 centimeters. And when they go back for the C-section, the doc goes, oh boy, that was super thin. Like you were close. Like if you labored any longer, that thing might have opened. But it sort of...
It's just because women want a natural birth?
No, it's not natural birth. If they want a vaginal birth. So vaginal birth is safer. There's a risk to everything. I mean, that's the concern about VBAC. The concern of the flip side is... C-sections. So it's interesting because C-sections are riskier for the mom, but safer for the baby. Safer. Vaginal delivery is better for the mom and slightly less safer for the baby, right? So you lift a baby out, you don't have to worry about it getting stuck through the canal and do all that. So it's safer. But it's surgery, it's abdominal surgery, right? So the risk is infection, hysterectomy, hemorrhage. So those of us doing VBACs we have all of these mechanisms in place. So they have IVs ready to go and they have monitoring all the time. But yeah, it can happen. And it can be very, very bad. And so that's why VBACs at home aren't a great idea. People are doing VBACs at home, right? We don't have access to all that kind of stuff. So that's a rupture. An abruption is when during labor, the placenta peels off. And that's another thing you would go ow, 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 and the baby go wah, 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 and they run you back for a C-section for that too.
Could that be caused by a Hep B virus? Could that
Abruption,
be
no.
No.
Mm-mm.
Is that something?
No, I just remember placental abruption can also happen during a pregnancy, earlier in pregnancy.
Yes, it happens during pregnancy.
Yeah,
it's the bleeding during pregnancy.
Right.
Yeah.
Just by the way, that is something that if a woman has a placental abruption in pregnancy and they're trying to maintain the pregnancy till the baby is really healthy and viable, then she is most likely in NIDA all the way through that time. So just you can imagine the stress on a relationship if she's been in NIDA for much of the pregnancy.
Right, and a previa will be that too. So a placenta previa is when the placenta implants low in the uterus instead of up here or on the back. It's blocking the exit. And women don't know, they may know that at a 20-week ultrasound or a 28-week, or you have bleeding, women will have bleeding during pregnancy, we send them in, on ultrasound, they see the placenta's blocking. Right, and so there's it's pelvic rest, you can't put anything in your vagina for the rest of your pregnancy, for risk of bleeding, all sorts of stuff.
Why does it make you bleed by having placenta?
So if the cervix opens a little bit, it will bleed. So if cervix ripens or thins, things can happen. It's supposedly, I think it's kind of strange that you can't have sex, but the idea is if you have sex, You can have uterine contractions. Some women get contractions from intercourse, and there's prostaglandins and semen. And so the idea is any kind of contractions can cause that placenta that's sitting right there over the cervix to tear a little bit and bleed. So they're on precautions.
Do midwives do C-sections?
We have patients who get, like I have 2 patients right now who are planned C-section. So they come to us, but I don't do the surgery. I mill about and take pictures and get the baby to them. I'm the staff photographer with them. That's a fun job. There are midwives who scrub in and actually first assist. I have a bunch of friends who first assist. It never has been my practice. I learned that early on, and then I was like, I don't want to do this. Like, I want to be with the mom. I went into this gig to be with the mom, not to like see the insides of her. So there are plenty of people who can do that. So, all right. So that's so postpartum hemorrhage anyway. So anemia, weakness, fatigue, and the really big thing is that whole milk supply issue, and it's just hanging in there, and it's pumping, and it's hydrating, and it's getting as much iron as you can in you, and sticking with it. And for someone, there's a lot of guilt around that. But you may see that. So lacerations. So there's 4 different kinds of tears. First degree is just skin of the perineum. Second degree goes into the muscle of the perineum. Third degree is through the muscle to the rectal sphincter. And fourth degree is through the rectal capsule, so that it's torn all the way through into your rectum.
How common is that?
Not very common spontaneously. I don't have numbers for you. Spontaneous meaning you just have a baby and the baby comes out and there's a 4th degree. Very unusual. 4th degrees are sequelae of an episiotomy. So if you think about it, when you're pulling on, I always say, like when you're pulling on if you're pulling on pantyhose, it's not going to rip. But if you have a run in your pantyhose and you pull really hard, it's going to rip all the way down. Which is why there has been a big shift in OB away from episiotomies, now even OBs. And now at the hospital, episiotomies are something that they track, and you actually have to justify every episiotomy you do now. Midwives haven't cut episiotomies for 100 years, but now the docs are like doing all this stuff with the oil. In my hospital, they're like putting people on their hands and knees and lubing them up with oil and doing all this stuff.
Is that like everywhere that this thing now?
Yeah, no, episiotomies are one of the markers that you're...
Like a huge lawsuit that just happened. Is that because of that, or?
You mean that someone said you gave me that thing that was all over Facebook or whatever? Yeah. That she was like abused for the... Yeah. Well, I think because you have to actually have a real reason now.
Part of value-based care.
Yeah.
So
Yes. It's like a Marsha.
A doula who worked with me before my first. This was this was 14 years ago, and she was obsessed with we don't want you to have an episiotomy. We don't want you to tear. To the point where she had this little device that was like a balloon that I was supposed to basically give birth to the balloon in increments so that I would get stretched out enough to not tear.
Yeah.
And the funny thing, after it was all said and done, I tore anyway.
Yeah.
And I know quite a few people who don't tear at all, people who tear severely.
Right.
And in the end, I was told, listen, this is just how you work. And that thing didn't do anything for you.
Right.
So it's just funny because she was so scared of, whatever was going on then with episiotomy, she was so scared of it happening to us that, we had to go through this little training program.
Yeah, it's interesting. I had somebody, a similar-ish story to that. I got a patient on her second birth. She had a first birth with the docs at our hospital. She told me this crazy story. She had a crazy postpartum complication, like a hematoma of some internal artery, something insane I never heard of. It was terrible. I was like, well, that's never going to happen again because I don't even heard of it. And it turns out, I talked to the docs, debrief with the docs, do you remember this patient? She had used this crazy device, not that, but some crazy device that she brought with her into the hospital that was supposed to protect her perineum, and they were convinced it put so much crazy pressure in the wrong parts of her perineum that actually that did damage. And I'm like, it sounds like a medieval torture device thing.
The thing was crazy. It was a little blue balloon.
Right, right. So my patients,
Let it now. Like,
Right.
How did I get talked into even?
Right. Well, because you'll do anything. I mean, when I took my second pregnancy, my first pregnancy, I was a midwife for like 6 years by then. I took my pregnancy test, and the first thing I thought of was like, oh my God, my perineum. Like the first thing, because mine is, there are long ones and short ones, and I was like, mine's short, it's gonna be terrible. Like I was really freaked out about it. The good news is that it was all set up this way to work, right? I mean, if you had to cut ourselves open to get it out, it wouldn't have been not the way that it all would have come down, right? So, there are all sorts of recommendations for women. Women talk a lot about perineal massage. That's the thing that's out there, which is similar to sort of what you did, but a little different, which is getting in there with lube and pulling on it, pulling on it, pulling on it all the time, and pulling on it, and stretching it, and pulling on it. And I'm like, please, like, stop. Like, it's insane. Like I said, it's, yeah. So I say to people, one, you're pushing, it's doing this, right? Is not what the baby does. The baby's coming from inside with force to the outside, not from the outside pulling. So it's not even the same mechanism, and as you know, the mechanism is sort of like I talk about, it's like a fist on I talk about this with cervical dilation, but if you imagine a fist and a lump of clay, it thins it out, right? Thins it out. Like that. So that's what the head's doing. It's thinning out the perineum, going, and this does not really seem to me like that's the same issue. And I said, when people ask me, I said, it's also like, knowing my luck, this is what would happen. I would be doing that. And the night before I did all this perineal massage, I'm all irritated. I go into labor that night. And then I have this irritated vagina that I'm trying to actually push a baby out, and it'll rip because it's all irritated. So there's no real good medical support, research to support all this perineal massage that people are doing. The thing that does help women for the perineum not to tear, and you can tell women this too. Again, if you have an epidural, you're sort of stuck because you're sitting there like this, you're getting IV fluids, and it's all collecting right here. I mean, the IV fluid is going right here. So women who go to push after they've sat all day with an epidural have the gigantically swollen, full of water vaginas that don't stretch that much. They really don't. We all cross our legs. So that's kind of a problem. The hospital tries to, we rotate you around and stuff. So if a lot of your ladies are getting epidurals, it's sort of hard to do some of that. But the three things that help perineums are position of delivery. So instead of being, flat on your back with your legs up in the air or in stirrups, which just pulls on the perineum, side lying is much better to get a baby out without it tearing, hands and knees, anything that's not like just pulling that as hard as you can. Position, and that's supported by research. Position, lube. So in my hospital, everybody has a little thing of mineral oil that we all use when the baby's head is crowning, and we lube up so the friction is less. And so your ladies, if you talk to them, can ask their docs about this. And hot compresses, which I use a lot now for all the swollen.
That just makes it feel better?
No, to help it stretch. So I just had a birth like 3 days ago, and I used this hot compress. I could not believe, and the baby came with a hand by the head and did not tear. I could not believe it. So everyone thinks if you're swollen, you put ice on it, right? But the goal in labor is you want that skin to stretch, right? And so ice actually vasoconstricts. It moves the blood out of the area. Right, and you want blood flow in there to keep the tissues pliable. So actually heat will bring blood flow to the area. So I slap, when the baby's crowning, we have hot, like Insti hot packs. I just slap them on the woman's perineum. It feels good actually, but it really helps. And that is supported by research instead of putting ice on there. So lots of midwives do heat down there too. Anyway, so first degree are little, those are the couple stitches that you get down there. Second degree is usually people recover really fine with that. You're sore for a little while. Third and fourth degrees are a little more traumatic. You have a lot of suture in there. First of all, the repair is sort of longer and more traumatic. If you have an epidural, then you're fine because you're not feeling much of it. If you don't have an epidural, it's really yucky to have those. You're just the doc or the midwife's down there for a long time. We numb you up and all that, but it's just it's a lot of manipulation. So you're getting, besides having a baby come through, your hands in there for like an hour trying to. So afterwards, you're super sore. Go home super sore. Really hard to sit. And then the issue of bowel movements and bowel management. So women who have had either episiotomies or deep tears also need to be on really good bowel habits because you don't want to be pushing too hard down there. You want everything to go, that the sphincter, your anal sphincter has to recover, right? So you have to have the things going through there real soft and loose. And so if they were sent home with stool softeners or that whatever, that one, if you're seeing them postpartum and they had that, one of the things they ask is like, are they keeping everything moving down there? And milk and magnesia is really great, magnesium, anything like that to keep things rolling.
So out of curiosity, in your experience, do you find that women who don't have an epidural recover faster?
I find that they are two things. One, they get up and out of bed sooner, which makes them feel better. They get up, they can take a shower, the birth is done, you're done being like the patient, you're out, you can move around, do all that, and you can be more mobile with your kid. A lot of women complain about the backs, the back stuff, and the anesthesiologist will swear to you it has absolutely nothing to do with the epidural. But they take a pretty large gauge needle and stick it through your muscles in your back. And sometimes they have to do that 2 or 3 or 4 times until they find the spot. And so there is back pain. I mean, women, and that'll take 2 or 3 weeks. And so in that sense, women who haven't had epidurals don't have that, right?
Back labor affects that.
Just like from also aside from a perspective of talking to new moms, I had a friend who had her first and had one of these really horror story tears, and one of her first concerns was I just got married and had my first kid and I'm ruined down there,
right?
And I could see that being something that moms will deal with, that fear of I just got married and had this baby and now what's gonna happen to me.
The good news is that it's amazing. First of all, the vagina is amazing. It heals just fine. It turns out you're...
I've had 2 more kids since then.
Yes. I mean, it really... I have seen some tears that I'm like, this woman is never going to have sex again. Oh my God. Like an exploding vagina. I call it the exploding vagina, where it doesn't just rip... It just doesn't rip deep. It just rips everywhere. It's everywhere. And I think oh my gosh, she's never going to, right. I was thank God. And then they come back 6 weeks and I'm like, have you used that area recreationally yet? And they're like, oh yeah, yesterday it was fine. I'm like, really? Really? Because I had a labial tear. It took me 6 months. So the good news is that it feels really cruddy for the first week or 2, and it's really challenging. The sitting, the pooping, you have PTSD to try to poop, that kind of stuff. And it heals. It's amazing. It heals really well and really easily, and it really, to have follow-up problems for that is really unusual.
The only thing that ever happened that was just kind of unexpected and disastrous for me was my first birthday, and I had my little tear, and this was in Israel. I had midwives do the delivery, but then the doctors come in and they're like, and he's putting my stitches in. I don't know who he was, but he kept telling me he was going to make me go to.
Oh, that's
He really sewed me up tight.
Yeah, they had that whole thing you wanted me, that's just hideous that people say that. Yeah.
I mean, that was more painful than the thing itself. And when I went back to my doctor later in the week, he took the stitches out and said, you didn't even need these stitches. I mean, so
yeah,
if anyone's having really horrible pain.
Well, and certainly, right. I mean, there is some normal pain that you have postpartum. Postpartum, just regular without stitches, there's a certain amount of pain. Stitches will, because it's suture, it's foreign object in there, and the tear has to heal, right? It's going to feel pretty cruddy. But if there's lingering pain, if you see women 2 weeks later and they are still, it's crazy down there, they need to be seen, because there are things, stitches, it's unusual, but stitches can open up and they can have an open area that feels really terrible. Things happen, or granulation tissue, which means that, they sewed everything up, but there's this little area, that kind of slipped through, and that's irritating. So it's not something, it'll be fine. People are always happy to look, because things can go downhill and badly very quickly, or if it's left alone. So they should definitely go back to their provider if their crotch is feeling bad at 10 days and 2 weeks and it's still as bad, or feels something is not right down there. We encourage our women to look down there. I don't know if people are scared to death to look down there. And I always tell them, go home and look. It's going to look bigger than it was and kind of loose. But it doesn't look like it's not like they staple it together and it looks like Frankenstein. It looks like some women never looked at their vaginas and then they go what is that? I'm like, that's your vagina. They're like, there's something hanging out of my vagina. I'm like, that's your vagina hanging out of your vagina. Like, after you've had a baby, especially your first baby, you're like, this is what I say, this is what you look like, this is what your vagina used to look like. And now it looks like this. But that's normal, right? It is. And so people think like, my uterus is prolapsing. I'm like, no, that's just your vagina walls. You're seeing it because it's open, that you could see in there, which is before you couldn't see in there. So, but pain, so bigness and looseness, that'll all go away. But like real pain, I'd say 10 days to 2 weeks, it shouldn't be pain 10 days to 2 weeks postpartum. Yeah.
The first time that I went to a midwife I started off with, it was considered high risk because I was 36 with my first child. Or no, I was 37 or 38 or something like that with my first child. And 37, I was 37. And so I had to start off with an OB. And I thought, this is ridiculous. I'm not like, just because I'm old, no, I'm switching to a midwife. So I switched to a midwife. And so the first appointment, she takes out this mirror and she said, here's a mirror. She puts it down there and she said, that's your vagina, get to know it. I was like, what?
Right. It's so true. Like people, I don't know. I was like, there's something hanging out of there. Always cracks me up. I'm like, no, that's just what it's supposed to look like. But we don't know. Plus, I see 50 vaginas a week. You've maybe seen 3. You've seen yours, maybe your daughter's. Like, people don't know what it's supposed to look like. One woman's like, it's flat ever since my delivery. My labia, they're like flapping together when I walk. They smack into each other. She's like, it's hideous down there. I want vaginoplasty. I'm deformed, whatever. I'm like, it's really fine. That's what labia look like. They're like, no. I'm like, that's what labia. I've seen more than you've seen. That's what it looks like. Yeah.
I want you to just be able to finish before we take
Yep.
any more questions. And
Okay.
If anybody, I just want to be mindful of that.
Yeah, there was something that came up about the lacerations that somebody said something that I was thinking of. Okay. Anyway, and so the only other thing this list is not whatever, but the other thing I came up with was if the baby ends up in the NICU. So that's very stressful on mom, emotionally and physically. So most women go home and then we tell them to lay down, do nothing but feed the baby and recoup and convalesce. And with a NICU baby, those women are doing way more than women would do normally. Especially they get discharged, the baby stays in the NICU. And so depending on how far they live from the hospital or if the baby gets transferred to CHOP or something, there is a lot of schlepping and doing things you're so focused on the baby, you're not thinking of yourself at all. So those women are losing more blood because they're walking around more and they're bleeding more. All those issues you guys have about bleeding, so they're losing more blood. They're not resting, so their crotch is going to hurt longer. It's still going to be swollen, like all of the things, they're just really behind the 8 ball. And if they have to pump and then the breastfeeding initiate, so it's a whole, that everything we've talked about on top of the fact that they're running back and forth or sitting by a bedside for 9 hours or sleeping if they have what do they call those rooms? Not boarders, but when they can stay at the hospital, but like nester, or like the nesting room, where they're not a patient anymore, but they can sleep over. So now sleeping in a strange hospital bed by the NICU. So, and you can imagine them. So you'll see those women again. They need tons of support, and they need to take some time. I mean, they need some time to rest. And to give them permission to rest or something and their recovery is going to take longer and they're going to bleed for longer. If you don't convalesce in the beginning, you bleed longer, heavier and longer. So that's going to affect sort of their postpartum course as well.
We are seeing some incidents of postpartum depression, postpartum anxiety with NICU moms specifically. There's some new studies that are coming out, significant studies that are taking a real look at the mental health impact of having a baby in the NICU. So there's just a little bit of a higher risk for these moms.
Certainly.
Is that because because something's wrong with their child, or do you think it's because they didn't have time to recover?
All the above. I would imagine it's all the above. Fear of how the baby's doing, not being able to convalesce, not able to take time for themselves to recover.
Guilt, depending on why they had why the kids in the NICU.
It's also hypervigilance.
Yeah.
Yeah, I mean, there's a hypervigilance that also develops, so something could be wrong at any minute. So.
Yeah, and especially if it's really hard. It really knocks you off course if it's your first kid. People say it's terrible when any kid's in the NICU. Even with a good prognosis, the baby needs to be here for a week for antibiotics, and that's it. It still puts you in a whole different place. The dinging, the 24-hour, you feel like you're in Vegas all the time because the lights and your days and nights are all mixed up. But people whose first baby it is it really knocks them for a loop about that. So you may see that. That's all I got. Any other clinical stuff?
Just about the afterbirth bleeding, also with an anal fissure. Do you find that?
So anal, like a fissure is really just like a, so like a little tear.
That can be caused from birth?
So people use fissures a lot. I have a lot of patients coming in and use the word fissure all the time. I mean, not all the time, but they'll use that word like someone told them they have a fissure. And I was like, all right, it's just like a little boo-boo on your rectum and all. Like fissures, like a fistula is a bad thing. That's like a passageway from one thing to another, right? That's when you have like poop coming out of your vagina, like you shouldn't. A fissure is like a rip or a tear or any kind of scrape. So when, pushing, things get irritated down there, and depending on how the baby comes out, I know what I was just going to think. There was something I knew with vagina, so I'm going to get back to it in a second. I just remembered it. Those will so yes, those can bleed. It's really just, it's hard for the rectum to heal really quickly because you're using it all the time. You're wiping it, and you're scraping it, and it's just a hard area to heal. So some women, have the hemorrhoids or maybe need the hemorrhoids excised afterwards. People can push and then end up with hemorrhoids that get like a clot forms inside and then has to be like opened up and popped out. It's terrible. But then you have like an little opening like on your rectum. So, and it's hard, those take much longer to heal because it's wet, it's moist, there's blood there. So that just makes for, yucky sitting, a lot of side lying, but it can happen. I know, sorry, Lisa, you should like walk out of the way. I know what I was going to say. I don't know if you guys have covered this, but getting back to the sex and the tearing and the crotch afterwards, women who are breastfeeding have a slightly harder, they have a longer crotch not feeling great time frame, okay? So women who are breastfeeding, their estrogen, in order to make milk, your prolactin is high, your estrogen is low. They work opposite each other. So when your prolactin is high, your estrogen is low, postpartum, for however long you're breastfeeding until your period comes back, you're like perimenopausal or menopausal in your crotch. So the first time they do go to have sex, regardless if they had tears or no tears, you have nothing going on and you are breastfeeding, it's the first couple of times you have intercourse or for a while may feel really not great at all. And lube is important, so someone else talked about this. So lube is really, and there's a couple of factors that make it not so great down there. One is that there's no estrogen, so it's kind of fragiler down there. It's just so that the tissue is not as robust and juicy. The lack of estrogen also means your libido is in the toilet and you're not really interested at all. And usually there's a mismatch between the partner and the postpartum women about when to initiate intercourse. This isn't sexual anymore, so this was on the list, the menu, and now this is off, and so you're left with this is a factory, and this is like perimenopausal, and so there's nothing going on. So for women, it's really like on the like number 15 or 20 on the list of things they want to do, like a nap, would be like way ahead of the game. So that's something to just reassure women, and when I see them at 6 weeks postpartum, almost none of my patients have had sex by 6 weeks. We tell them they can have sex after they stop bleeding. And for some women, they bleed until 4 to 5 weeks, so they're not ready to jump on that bandwagon yet. But it's really, really normal for intercourse to feel completely different for a long time. And there's nothing wrong with them, and it's not going to be like that for the rest of their lives. And so what I tell women is some people come back and they've had sex, it's fine, and some people take a much longer time. When your period comes back, whenever that is, and you're fully estrogenized again, you have your cycle coming back, and all your hormones are back, you get your old vagina back.
Even if you're still nursing?
If you're nursing but your period comes back, you've gotten your estrogen back. And so for some women, it could be 6 months, it could be 9 months, it could be 14. I didn't get my period back for 14 months, so it depends. But
Mine back at like 2 months.
Some people nurse like crazy and get their periods back at 2 months. Yeah. So, and some women will want to get pregnant again sooner, so they'll wean sooner. But so that's really challenging because what's wrong with me? I should want to have sex. No, like you shouldn't want to, and there's some pressure there to do that. So lube is important, and they make all sorts of lubes that are more like women's actual vagina secretions versus just like KY.
Just by the way, in the packet that we're sending home to all new moms, there's a sample of that from the pelvic floor disorder specialist.
Great. So the other thing is that if it continues to hurt, and they try to have sex and it doesn't feel right, or there's one spot, it's like that, there's just like one area, we can treat that with estrogen. So they should go back to their providers. And I talk about this with my patients at 6 weeks. So sometimes everything gets sewn up, but there's one little area that didn't, whatever it is, or the nerves are a little just funkier there, or it just doesn't feel right, or there's some granulation tissue, or there's something going on there, you can actually use topical estrogen to sort of beef it up and make it feel better. Or right at the where the tear was and it grew in, there's some scar tissue there, and estrogen really helps to get that pliable. And it's just local. You're not putting it all the way in. You're just smearing it on, like using it as a topical cream, and that's a really easy thing to do. So
Is that a permanent fix, or that's like on a?
Just until you get your period back, or until it feels better. Yeah, we use that a decent amount. So that's another arsenal thing that they should go back and talk about getting something like that.
Can people see midwives even if they're not planning on having children?
Yeah. So most midwives do GYN, like woman GYN. Yeah.
Oh, really?
Yeah. Oh yeah. All right.
Just being mindful of the time. Any other last questions? This was fantastic.
Yeah. Are you gonna put in the packet, because maybe they were unhappy with their whatever? Are you gonna put recommendation or list of midwives maybe, or doulas?
We did not. We included doulas. We did not put midwives. There is some concern of us like referring.
Oh, I see.
And we just chose not to do that. But I feel like we have enough. If somebody says, I hated I met this lovely midwife and I really liked her. You personally are more than welcome to recommend if somebody asks you. Absolutely. But as a professional organization, I can't make those recommendations.
I meant to bring my business cards just to give you guys each, so you could reach me if you had any issues, or I'm
sorry, their name is on there. We didn't include. Okay, I wasn't sure. Okay.
But anyway, my email, if you just want to put this down, our email for our practice is our practice is Woman Wise Midwifery. There's actually a Woman Wise Midwifery that does home births only, based out of Maryland, that has this very close to my address. But anyway, our website is womanwisemidwifery.com. But anyway, our email for the practice is www.midwifery@gmail.com. So if you have whatever, you feel free. It's
Do you take insurance?
Yeah, we take insurance and we have it self-paid.
What is it?
Woman Wise Midwifery. But it's www.midwifery@gmail.com is my practice email. So like, hey, whatever, if you have a question of anything I said, or you have any, whatever, you want to send something.
Yeah,
That's what I'm saying. Send out.
Yeah, I forgot to print out the evaluations that we really need. So, Aliza, can you send out her information? I'm going to give you a copy of the evaluation. If you could just, fill it in and send it back to me, take a picture of it, scan it, whatever, just send me back the evaluation, because we do need to keep track of those. And just keep looking through your email box over the next couple of weeks and over the next couple of days. And please, please, please come pick up the bags.